Okay, sir.
Should I go ahead?
Meena, sir, you can take over, sir.
Okay, the first one is the Dr. Bola is the first speaker now.
Yes, sir.
Hello, good evening, Dr. Bola.
Good evening, sir. Good evening, sir.
क्या हाल है?
बिल्कुल ठीक है, sir.
चलो करो स्टार्ट. Can you
ठीक है,
start?
ठीक है, sir. प्ले में कैसे आएगी? ये प्ले वाली जगह
Play
पे
वाली बटन पे दबा दीजिए, sir. On the left. Yeah, that one.
Respected panelist, Dr. Akanksha, Dr. Rajesh Rola, Tarandeep, and my dear friends. Today I am going to present few cases of.
Wi-Fi है there?
Am I audible?
Yes, you are audible.
Yes, sir. You're audible.
I'm going to present few cases regarding deformity correction with Ilizro and Hexapod. And I like to ignite the orthopedic surgeon, young orthopedic surgeon for this. And the mind is not a vessel that it can be filled. The mind is, it is a fire to be kindled. And for young orthopedic surgeon, I like to share that mentors, they play a great role. In my life, Dr. R.A. Agarwal, Dr. Mangal Parihar sir, late Professor Usten sir, Dr. P.N. Gupta sir, Dr. Vasudevan, Dr. Rajesh Rohila, and my dear Pankaj Bhatia, they were mentors. Most of the cases which I will present, somehow or the other, is the contribution from these mentors. Second thing I like to share that the books are also important, and many things which are written so deep, like page 443 in Drawer Pele, Principles of Deformity Correction, that human limbs are three-dimensional objects, and any limb deformity is more likely to be three-dimensional rather than two-dimensional. Axial alignment is recognized and documented more frequently than is rotation. What I mean to say, in most of my next cases, I like to stress upon that three-dimensional thought of the deformity should be kept rather than two-dimensional. As all of you know, we will not like to see the earth like a plate like this, the map. We like to see a three-dimensional object like this. Similarly, with the passage of time, from these X-rays, we will like to move toward three-dimensional picture of the bones so that we can address the deformity in all the planes. In last 15 years, in deformity correction, hexapods in India have revolutionized this deformity correction. And there were two main, Professor Leonid's SUV hexapod and Dr. Mangal Parihar sir dead fix. And this is a beautiful picture which is showing on one side there is SUV hexapod and other side it is the dead fix. This has revolutionized the deformity correction, and I'll request most of the beginners to start learning hexapods. You will see almost all of the front patients, they are having hexapods on them, and all the back ones, the hexapod has done the job. So, few lines about hexapod. Hexa means six, pod means feet. The six rods, they connect the two fragments, and if we change the length of the rod, shorten or lengthen them, the position of the fragments that can be placed in the desired position relative to each other. Without the hexapod, first you have to distract, then you have to apply hinges to angulate, then translation devices for translation, rotation. But with the hexapod, you can do all the above things in one go in a much simpler way. This will I show you by a simple example. If an ant has to go from the floor to the roof, it will first travel on the floor, then it will travel on the wall, then it will go on the roof to the desired position. But with the hexapod, the wasp can draw a direct trajectory. It can fly to the destination directly. So this is what hexapod does. It saves time, it simplifies corrections, it is less strenuous to the regenerate. And it's a kind of safari. I like to show you these things in the next of my slides. And let's start with the Genu Welcome, both the sides, 17-year male. It's mainly Genu Welcome, but if we see, there is from the side, there is FFD of the knee as well. So you have to look at the deformity from all the sides. From the frontal plane, full length AP, in all the lower limb alignment, for deformity correction, we have to have MAP and ABC. What is MAP and what is ABC? Like in this full length X-ray, first we draw the mechanical axis from the center of the head to the center of the ankle, and you see there is valgus, M, then A, map, M has been done, A. We draw all the joint angles, upper end of the femur, lower end of the femur, upper end of the tibia, lower end of the tibia, and find out where the flaw is. Then is the P. We pick up the bone. As proximal and distal joint angles, they are almost normal. It is the lower end, it is the femur, lower end, MLDFA, which is 71, and MPTA 107, which means both femur as well as tibia both are at fault. Then ABC, where is the apex of the deformity? Like in this femur, if we take the anatomical axis, proximal anatomical axis and distal anatomical axis, they do not intersect in the inside the bone. That means the deformity is not one, there are two coras. Similarly, for the tibia, the proximal and the distal anatomical axis, they do not intersect inside the shaft of the tibia. So there are two coras. And B becomes bone cuts, like in this tibia, and in the tibia, once proximal and distal, both the anatomical axis, they are connected within the bone, and we find cora 1 and cora 2. And then becomes whether you are going to do it acutely or gradually, A, B, C, C. In all the rest of the cases, we will show that this formula is to be applied. And then we make the frame, we make the hinges, and in large corrections, soft tissue, they have to be taken into consideration. Like in this, we did lateral popliteal nerve release. So we did fibular osteotomy, we did upper end, first cora and second cora osteotomy, and this was the, after this, we did the same thing on the femur, and after 1 year, right side was then addressed. Again, here we changed one thing, that instead of hinges, we applied hexapod for the femoral osteotomy as well as for the tibia, and these are the final results. Both the sides, they have been corrected. This is the sagittal plane. And take-home message is Genu valgum is not always a deformity of the femur. It can be both femur or tibia or either of them. Second thing, if more you get mature in deformity corrections, the better the results are. What I mean to say, first we did left side, then do right side. The correction of the right side is much better because I had the experience of tackling this situation. The third take-home message is in one bone, there can be deformities also at two levels. And the fourth take-home message is neurovascular structures in large deformities, they have to be taken into consideration. Let's have another example of Genu Verum Rightni, 24-year female who is having deformity of the right side. Sorry. She had brought her own frontal plane scanograms. So let's calculate on this. Once we applied a map and analyzed the joint angles, we found that it is the lower end of the femur and upper end of the tibia and lower end of the tibia, they are giving varus. And then ABC, how much is the deformity at the lower end of the femur? How much is at the upper end of the tibia? How much at the lower end of the tibia? And then where the cuts should be there, where the osteotomy. So 3 osteotomies were to be done. Let's go back to the first step, review it. The patella is not centered as seen on the scanogram which the patient had brought. Once it is not there, we I did frontal plane scanograms again. And what did I do? The patella was centered, there was a marker, and as the limb was showed by 2 centimeters, the blocks, they were kept so that the pelvis is square. Let us do the calculations now. The calculations, they were done on DICOM images of Horus. This software is available only with the Mac. And with this, you can precisely find out where the deformities they are there and how much they are there. And once we now calculated, we found that the lower end of the femur was normal. The deformity was only at the upper end of the tibia and lower end of the tibia, which means we can avoid one osteotomy at the lower end of the femur. So do not hesitate if you find the scanogram with the patient is not fulfilling the needs. We also confirmed these things with the CT scans, which gave us centered patella, and you can rotate the whole of the limb and find out where is the AP and where is the lateral. Full length lateral view exact can be found out. And the third dimension, rotation of the limb, femur or tibia, can precisely be noted with this. So again, we can plan so nicely where the first cut will be there, how much will be the distance from the joint, second cut will be there, what will the length of the rings, etc., etc. And we can also prepare 3D models so that we can really look into what we are going to do. The more we know about deformity, the better we will deal with it. Then preoperative Ilizro rings blocks, they were made. And we always have a page on which we write down what was the size of the rings, what is the distance between proximal rings, what is the distance between the distal ring, and what is the angle. These are the operative steps. Most of the time I am doing only shan pins I'm using for the frame of the tibia. Like in this, first lower end of the tibia, first frame, then upper end of the tibia, shan pin, and the frame has been suspended. Then rest of the pins they have been added and tibial osteotomy has been done at the lower as well as at the upper end. And this is the picture, second postoperative day. Slight correction was to be done, which was done with the help of hexapod. And this is the sagittal plane that as well. And this is the hexapod which was used. And these are the 7 months after the full length AP view as well as the lateral view. This is the clinical picture. This is before and after. What is the take-home message in this? Proper full-length X-ray should be there. If it is not proper, then might be you will do an osteotomy which was not needed, or you don't do an osteotomy which is to be done. One thing. Second thing, two deformities of the same bone might be there contributing to the final deformity. And the third take-home message is joint line angles must be drawn for hip and ankle. If in this case, I did not draw the joint line angle of the ankle, I would have missed the varus contribution by the lower end of the tibia. So with these two take-home messages, I go on to the next case. What should be done in this case? Who is 52-year-old male? There's pain in the left knee since 6 months, and he cannot walk more than 1 to 2 minutes. Or supracondylar osteotomy, or TKR should be done, or osteotomies around the knee. So there is confusion, and most of us will say we should do TKR. Let's have the full profile. There is history of correction of genu valgum at the age of 20 years. Now femur is in varus, tibia is in valgus. There is FFD of the knee, severe osteoarthritis. So even before doing the TKR, excuse me, we must correct. If the deformities they are larger, they first must be corrected before TKR. Here, femur varus was there 31, tibia valgus was there 13 degree, and FFD of the knee was also there 24 degree. So before doing TKR, we addressed with the supracondylar osteotomy, which also did HTO to resolve both femoral as well as tibial deformities in both frontal as well as sagittal plane. In supracondylar, we resolve 30 degree of valgus as well as extension of the knee. In HTO, we resolve the varus. And these are the final results. 2 years, 6 months. This is the sagittal plane. So both are important, frontal as well as sagittal planes. This is the preoperative. Now he can walk up to 4 kilometers in one go. This is the function. And this is the clinical picture. This is the knee bending. Initially, at the age of 20 years, the valgus corrected, and it was corrected at the femur only, while the deformity was also there at the tibia. So whatsoever you did about 20 years back was not good. So you have to do now, resolve it now. Deformity was overcorrected and it created varus at the knee. It also changed the obliquity of the joint line in the frontal plane. Valgus knee does not mean deformity of the knee. About 20 years back, it was thought like this. Deformity should be corrected at the bone or the bones which create the deformity rather than the nearby bones. So osteotomies around the knee, they have many areas which are undigged. And
पहले 2 मिनट चलता था तो मैं थक जाता था, अब 2 घंटे चलता हूँ तो नहीं थकता।
चलने पे कोई दर्द तकलीफ नहीं
नहीं
आपको?
होती है।
मतलब
he says from 2 minutes he have moved to 2 hours without pain, without tiredness. Another thing, basic principles of external skeletal fixation using Elizarov and other devices by Professor Leonid Sir, he has mentioned you may also want to seek the advice or counsel of a spiritual mentor prior to hospitalization. What does this mean? To every patient who is having long standing deformities, he must, prior to operation or anything, getting it corrected, get connected to whatsoever belief he is having or the mentor, religious mentor he is having. I make it a routine that every patient does it. One more concept I will like to share with you is dynamic functional feedback correction. Deformities, they can be resolved acutely or gradually, or part of that acute and rest gradually. It is in the gradual corrections that functional feedback correction can be done. What does this mean? I will explain it with the help of a few slides. He's a 21-year-old commando on police who sustained fracture of the right tibia after a fall 10 months back. And successful conservative treatment with plaster has been done. Bone union is very good. And he consulted few doctors who advised good union is there. Just wait, physiotherapy, and you will be all right. And should surgical intervention be done? About 20 years back, I would have said no. But I think we should dig it more. Before the injury, he could walk and run 20 kilometers per day. And after 10 months of injury, he can only run for 6 kilometers. And there is limping. And patient doesn't feel like walking and running because these are uncomfortable. The strain in the knee on walking and especially running, and hence there is functional disability. Right side is loading less, only 80%. The left one is loading 100%. Let's measure the amount of deformity. We did full length x-rays and found tibia varus 12.8 degree. Slight internal rotation of the tibia. PPTA was 74, 8 degree up, procurvatum was there. We clinically checked the FFD of the knee, and on standing, all the weight being borne on the left normal lower limb, no weight on the right fracture lower limb, because there is FFD of the knee, and on loading it, quadriceps has to contract to stop knee from buckling.
अब ये मूवमेंट नहीं होती बिल्कुल भी, ठीक है। जब आप इस पे जोर पाते हो तो इसकी जो है मूवमेंट हो रही है अच्छी खासी, ठीक है। अब इस पे पाओ पाओ जोर, इस पे और जोर पाओ, ऐसे और बिल्कुल ऐसे, ठीक है। इसकी मूवमेंट.
This means that on loading while walking, quadriceps is always in contracted position. Why Elizarov and Hexapod in this case? One, he's commando. Secondly, he will get surgery done anywhere without spending even single penny. Third, he has to go through time and again metal detector for security reasons and doesn't want any metal inside. Fourth, he doesn't want any surgical intervention to remove the implants later on. So he searched me and came to me. He preferred Elizarov, which fulfilled all his demands. So we did osteotomy and corrected in both the planes.
ये हड्डी मुड़ी हुई जाती लगी था, और जब रनिंग करता था तो ये पैर अंदर की तरफ जाता था, और इससे मेरी नी में भी दिक्कत आ गई थी, चलने में आगे डरती थी। अब सर के पास आया, सर ने ऑपरेशन किया, 29 का ऑपरेशन हुआ। अब 30 को सर ने सलाह भी दिया मेरे को, सारी मेरी प्रॉब्लम सॉल्व हो गई।
Let's see how much correction should be done in these cases. How much should be PPTA? It should be 87. It's the range. Look for the normal side. And on the normal side, it was tibia vera. MPTA was 83.5. So should I make it also abnormal, tibia vera? Or Now I have a chance to correct it to desired normal position. So what should be MPTA? 87? Because it is a range, should I correct it to 85, 86, 87, 88, 89 or 90? It is here Elizero and Hexapod, the best tool. You can match the corrections with the function of the patient. We can keep on correcting till patient says loading is getting better. We can titrate it, stop it, go back as per feedback of the patient. This is what I mean feedback dynamic correction, dynamic functional feedback correction. The deformities which can be resolved with gradual correction. It is possible. Why? Why should we do? Because precision. In certain situations, even 1 to 2 degrees of over or under correction can affect, enhance, or deteriorate the performance of the intended surgery, especially in athletes and in complex deformities of the lower limb at multiple locations in different levels, different bones, multiple malalignment, malorientation syndrome, with or without association of muscular atrophy like polio. So carry-on message also is sagittal plane is an important parameter to evaluate the deformity. FFD of the knee is a disabling deformity, and any fracture of the lower limb, frontal or femoral or tibial, can lead on to FFD of the knee. Frontal plane issues might take years to appear, but FFD of the knee issues they disturb immediately. This is the carry-on message from this.
तंग हुई हुई है, इस पे कोई लोड नहीं है, सारा लोड इस पे है और इसका ये पटेला बिल्कुल लूज है. अगर लोडिंग पे पटेला लूज है तो मींस कोई भी एफएफडी नहीं.
Please allow me to end in a lighter mode for this patient. In FFD of the knee, quadriceps muscle is always in contraction in stance phase, which leads to fatigue and functional disability. Quadriceps stance phase priapies, which leads to tiredness. One more case, 44-year-old lady post-polio lower limb with foot and ankle issues. She was operated upon and lengthening was done in the left lower limb, and since last 2.5 years, she is deteriorating day by day, mainly with pain in the right foot on walking and standing. She was referred by family physician in USA to podiatrist foot and ankle surgeon. One suggested triple arthrodesis, other said TA lengthening, third said if you do TA lengthening, you will destabilize the gait, and suggested better to go to the person who did the lengthening. Then they went to Baltimore Limb Lengthening Center, USA, and Sir Dr. Noman Siddiqui suggested foot and ankle surgery with tendon transfer. Then they visited Sir Professor Hasenberg, who did the lengthening of the leg, and he said, Dr. Noman Siddiqui is a good doctor, but he is not the right person for you because you are having polio. Consult Dr. Anil Bhave, senior physiotherapist who belongs to India, where large number of these cases are there. So they came to me, I assessed, there was broad heel with zero TA power and valgus of the knee, equinus, FFD. We started looking proximally, FFD of the knee and hip, that was also there, and equinus of 10 degree was there, FFD.
सब मिल जाए.
Supracondylar osteotomy was done to resolve FFD and valgus of the knee, and you see, preoperative and postoperative. Knee is neutral, no varus valgus in both the planes. There is no FFD. Heel has started touching the ground, and foot and ankle pain disappeared because now the foot was plantigrade. And the message is polio surgical intervention involves surgeries at different intervals. We have to start proximally from hip to knee to foot and ankle rather than other way around. And lengthening in cosmetic lengthening and poliotic should not be taken lightly. And proximal and distal malalignment of the bone in all the plane, X-ray should be done. If they are disturbed, later on they will produce harmful effect for the deformities, and the total outcome of which might be worse than even the original deformity. And also look for the problem and solution which might be somewhere else. She came for foot and ankle surgery. We did supracondylar osteotomy and resolve the issues. So take time, take 1, 2, 3 days. Find out whether wheresoever the bell is ringing is the problem point, or it is somewhere else. What surgery should be done so that she is relieved of her or his issues. Another lady, 55 year, and she's having pain in the left knee, which is progressively increasing since last 3 years. And you see left side, and should the HTO be done? FFD of the knee was also present in this case. As you can see, if the patient lies on a flat, hard surface and you can pass your hand below that knee, that means FFD is there.
स्टैंडिंग में जैसे आप
There is
उसमें भी प्लान होता है इस पे है एक्टिव होगा 70% उधर है 30%.
the loading becomes less, tiredness becomes more if FFD is there. The FFD of knee can destroy results of nicely done PKR. And we found out that it is the femur which is at fault rather than the tibia. So no HTO. We did femoral varus osteotomy and resolved both FFD of the knee as well as the varus of the knee. This is the Bone Ninja app. For beginners, it's a very useful tool and they must start learning how to use it. In supracondylar osteotomy, at the end and also after passing each wire or the shan pin in the supracondylar area, femoral condyle, you must do this thing. So that wheresoever tension is there, that can be removed. This is the supracondylar osteotomy which has supracondylar, which has resolved both FFD as well as varus, and these are the final results. The carry-home message is osteotomies around the knee to correct the osteoarthritis has to be decided after alignment calculations of the limb. It may be HTO, it may be supracondylar, or it may be both. Please use the fire extinguisher in the house which is on fire rather than the house nearby. So whichever bone is at fault, you have to address that only. Genu valgum, genu valgum, genu valgum. What does this mean? It is genu valgum, but there are other deformities as well. I'll show you. There is FFD as well, like this, both the sides, as well as there is rotational issues as well. So you can only resolve one thing or all of them. I am comfortable with Elizero and Hexapod, which we did in this case, and doing CT scans, preoperative planning. First did one side, then did the other side, resolved both the sides, and frontal as well as sagittal plane as well as rotational issues. It is here where the dynamic correction can be applied because you don't know how much rotation of the limb patient is comfortable with. You start with 2, 3, 4, 5, 6. The moment she says, okay, with 10, she is comfortable. After that, might be she's deteriorating, you stop there. And this is the hexapod, this is before, this is after. Again, the same test after the surgery. So these are the end results. If there is no osteoarthritis and it is genu valgum, we try to, and the end point is center of the knee joint. And few just slides only. Ilizro hexapod in compound fractures, they can be used also so that we prevent the deformities as well as treat the fractures. Non-union in malposition, preoperative planning, hexapod. This is once the alignment has been achieved and fracture has united, compound fractures, Ilizro, hexapod. Sometimes patient comes with a fracture and you know there is deformity as well. So you can address both. Like in this poliotic who is having shaft femur, he was having FFD of the knee. So we corrected both. We did supracondylar osteotomy. In the period in which the fracture had to unite, we also corrected the deformity of the patient. Another area, CDH, in which you have to make a hinge, which is very important and which is very difficult. If you have hexapod, you can do that very comfortably. HTO is another deformities which can be corrected with the Ilizro and hexapod. The same, another patient, once they have issues in both frontal and sagittal planes, this is a boon. And genu valgum, left side, genu varum, both the sides, post-septic knee with shortening. In this case, if you see very closely, there is FFD of the knee. First 30° of the motion of the knee is not there. So I did supracondylar osteotomy and the arc of the motion was changed to sagittal plane in which the motion started from 0° rather than 30° because the whole of the knee is destroyed. Another patient who came with osteomyelitis, we did sequestectomy, and there was equinus. We also corrected the equinus with the hexapod. So CTV is another. This is an area where Ilizro and hexapod, they are boon. 8 year, after 8 years, and this is CTV, which has been corrected with Ilizro and joints once dissected in foot and ankle, they can act like osteotomies and they can be angulated to correct the deformities. Once controlled distraction is applied along the bones, it can change the shape of the bones involved. He's an adult, CTV, very rigid. We did supracondylar osteotomy, supramalleolar osteotomy, as well as midfoot osteotomy, and applied 2 Ilizros on both the sides. One first was done one side and then the other side, and these are the results. Is another adult in which Ilizro and hexapod they were used. Last, where I started first in deformity correction, like this. Here deformities are there, bones, joints, along with that muscle weakness is there. This is what we did. And last slide, hanging lower limb. Here deformities are there, which are corrected with Ilizro and hexapod. Along with that, muscles are also weak. We might say there is hardly patients who need that, but there are patients of deformity correction and they need our services. And thank you very much, everybody, for letting me unite a young orthopedic surgeon for Elizro and Hexapod in deformity correction. Thanks a lot for your patience here. Thank you.
Thank you, Bola, for your nice presentation.
Thank you, sir.
One or 2 points I wanted to ask you. Particularly for the various deformity of the tibia or the femur, if you have encountered the problems of the physial bar, how do you treat them? Children with a physial bar.
You see, most of cases which I have shown, they were adults in which the growth was stopped. After that, I did the corrections.
You
So
have
I do
done
not
many.
have much of experience with epiphyseal bars, sir.
Do you have any experience of dissecting the bar also to correct the deformity?
Sir, I don't have.
And these patients, particularly if you have the varus deformity, a multi-apical deformity, usually these patients have the metabolic bone disorders. Most of the patients I have seen, most of the patients they need the. If you see the family history, most of the patients found to be hypophosphatemic rickets. So I think they need evaluation for the metabolic bone disease also.
You are right, sir. Whatsoever metabolic disease is there, we first correct that. We keep that in mind. And after that, we correct the deformities, sir.
One thing is, if you have a multi-apical deformity,
Yes, sir.
it's my personal, I'm not telling about your experience, but it's my personal experience is
Right,
that we
sir.
don't have the hexapod or the dissectors smaller. Personally, I have not used them. In
Right, sir.
multi-apical deformities, I often use only the correct them on the hinges.
Right, sir.
I think I am comfortable with the hinges to
You're
correct
right.
these multi-apical deformities on the hinges.
Right. Initially, I used to do with the hinges only, sir. Since
Yeah.
when I have started doing this, I find it more comfortable.
If you have the multi-apical deformities,
Yes, sir.
all the multi-apical deformity do you treat by the hexapod system?
Initially, once this system was not there, hinges and translation devices, etc., I used to use. But since when I am having these, I am very comfortable with the hexapod.
Do we have the smaller distractors?
Pardon, sir?
Smaller distractors.
These are mostly the patient which I treat. The hexapod, this hexapod, comes in three. One is large, another is medium, another is small. But I don't have for the very small children, but the smaller one does good for these kind of patient for me.
For treating the polio deformities, so you have a very excellent work on the polio.
Right, sir. Thank you.
And for the particularly, I am interested for the foot deformities.
Right,
We
sir.
often used to in the mature foods, we often used to distract them to correct the whatever the deformity we want to correct them by distracting the joints. And we
Exactly.
later on usually often we fuse them.
Right, sir.
Sort of triple arthrodesis and that.
You're right, sir.
And you are adding you're treating them by doing the osteotomy, calcaneal osteotomy and all that.
Mostly, I use the same thing what you are doing, that we just distract them. Once we distract the foot and ankle, these are just, they work like osteotomies. Whatsoever soft tissues are there, we also release them. Once the foot is neutral, we with plaster let him walk. Later on, if he wants, we can fuse the joints. Otherwise, a plantive grade foot does a wonderful job, sir.
Yeah, I'm telling you my personal experience that most of the time these bones are deformed bones and they
Right,
were
sir.
never regained in the normal position.
Right, sir.
So once we distract the soft tissues, then apply the plaster, keep them plaster, ask the patient to walk on,
Right,
and
sir.
later on in second stage we do the triple arthrodesis.
You're right, sir.
This is my personal thing. I
You're right.
am following that.
Right.
Any questions from the audience?
Dr. Bola, I want to ask something.
Yes, sir.
One compliment for you. It is a very nice presentation.
Thank you.
You cover most of the stuff of the deformities. I just want to
Thank
ask,
you.
have you ever encountered any MCL or LCL tightening after your surgery, especially around knee when you are correcting the deformity?
Whenever I do, you see, for tibial frames, knee motion will not be affected, one thing. With supracondylar osteotomies, it will always be affected.
Hmm.
Once you do the supracondylar osteotomy and put few shan pins or wires in the condyle, from day one, you take this case as a knee stiffness case.
Hmm.
So you on the table at the last moment, you give at least 90 degree of motion, one thing. Secondly, we keep these patients for very long.
Hmm.
About 3 months, you will be surprised. And we send them home only once 100 or more degrees of the knee motion is achieved. Rest of that, they can. Otherwise, you are right. If we do not take care or the patient goes home, he is treated of the femoral deformity, but he is now with a stiff knee. So from the very beginning, we take it as a challenge that he will develop knee stiffness, and we focus on that. And before the discharge, he must have at least 100 degrees of knee motion. Sometimes also after say 15 days, 1 month, we don't find much of the motion. We take the patient under anesthesia, do the mobilization.
And what
So
about
one
the
thing,
lateral and medial thrust? Uh, have you ever encountered?
We have corrected a lot of these thrusts. Once you do the alignment of the bone, then the thrusts they go away. One thing. Secondly, you make this is what I mean to say dynamic functional correction. Once they walk, once they walk, then you can correct varus or valgus, varus or valgus. By the end of that, by the end of the union of the femoral or the other tibial osteotomy, the varus thrust or valgus thrust will not be there. It is more offending once you do it with the plating, I think, where you cannot functionally judge how much to do, how much not to do. Once you have hexapod or eliso in your hand, posteriorly you can correct the things, then this is what was told to me by Dr. Mangal Parihar sir, and I am doing that. Once this thing is there, postoperatively I can change the mechanics, make him walk, eliminate the thirst, the patient they do well.
Thank you so much.
Thank you very much. Thank you very much. Karan.
thank you, Dr. Bola. It's an
Thank you,
excellent
sir.
presentation.
Thank you very much,
Excellent.
sir. Thank you.
Next speaker, Dr. Rohil, I think.
हाँ सर, मैं स्टार्ट करूंगा। डॉक्टर बोला आप उसको अपना स्क्रीन, ठीक है, मैं अपना स्टार्ट करता हूँ।
ठीक है।
मेरी स्लाइड विजिबल है?
Yes, sir.
Yes, yes.
अच्छा, ठीक है। तो आई एम प्रेजेंटिंग 2 cases. Screen. How to remove this upper screen bar?
Where is it, sir? It's not here.
नहीं, it's on my screen basically. Your
Sir,
all the faces are visible.
so on the top right corner, sir, you can find a small bar, very
Yes.
small bar. Just click on that, it will go away, sir.
I think it's gone.
Okay.
So a 16-year-old male had roadside accident. Patient was managed with a cross knee external fixation outside and presented to me with the pus discharging sinuses and exposed bone. It is not moving.
So just use the arrow key on the bottom.
Okay.
So on the right hand side, yes, sir.
Okay. So I did the radical debridement, and there was 12 centimeter gap, and distal corticotomy was done and started the resection. But corticotomy site got infected, and the patient had pus discharge from the corticotomy site. So I asked the patient to go reverse, and after the 3-month follow-up, the corticotomy gap was closed, and fortunately the corticotomy site pus got stopped. Then at 5-month follow-up, I did the curettage. There was one sinus near the corticotomy site. I did the curettage of the sinus and did corticotomy slightly proximally and started dissection again. And this is the 6-month follow-up. Dissection started. And 7-month follow-up, and the bone starts forming. 8-month follow-up, but still there is poor regenerate, so kept the fixator there. This is 9-month follow-up, and bone starts consolidating little bit. Distal fragment now have reached the proximal fragment and touched the proximal fragment, but it was in some, there was beak, so it was not in good contact. Allowed regenerate to consolidate there, and at 12-month follow-up, regenerate consolidates. Now good bone is formed, and I got the CT scan. The fracture is still not united, and now the limb starts going in valgus. Got the scanogram, and so as the limb was going in valgus, so I planned the deformity correction. The mechanical axis was passing lateral to the center of knee, and MPTA was 98 degree. So deformity was in tibia, and PMA and DMA were intersecting more well proximal to knee. So there was both translation and angulation deformity. Then I did the open reduction of the fracture site, made the both and transverse, did the bone grafting, and hexapod was applied for correcting the limb deformity. This is the 18-month follow-up, and fracture. Meanwhile, I checked the when it was on hexapod, I checked the alignment with the scanogram at that time. This is the 19-month follow-up at 19-month and 20-month follow-up. Now the fracture starts uniting in 21-month follow-up, and ultimately the fracture united. And I did the CT scan to confirm the union. Now it is confirmed, and fixator removed at 25 months of original surgery. This is the result. Patient had very good range of movement at knee and ankle, almost equal limb length, and bone result was excellent, and functional result was also excellent. So in this case, what I learned was how to manage if corticotomy site get infected. Can use advanced hexapod technology for deformity correction. It is easy with hexapod, and can do bone grafting at docking site early to achieve union, and in persistent effort with the laser of fixator can salvage infected non-unions. One more case. The patient is a 4-year-old girl presented with the varus deformity of both limbs. The deformity can be, it can be single osteotomy solution or double osteotomy solution. Both the planning of both is shown. Like then I did the in the left leg, I did the double osteotomy solution, applied the ring fixation, and with the help of hinges, I corrected the deformity. The correction was achieved, but as there was distal corticotomy, there was some delayed union and soft tissue healing problem at the distal corticotomy site, but ultimately that healed. Then other side, right side was corrected after 1 year, and I did only single osteotomy, proximally only, and applied the SUV. At that time, SUV was available. And this is the final radiograph at 10-year follow-up. Right side SUV has been done, and left side conventional Lizarov technique has been done. This is the angles at the 10-year follow-up. The patient has perfect alignment. This is the clinical picture, 10 years follow-up. Right side SUV was done, and left side conventional Lizarov technique was done. So take home message is, planning is most important, as deformity may be multi-apical, and you have to choose between single osteotomy or double osteotomy solutions. Double osteotomy solution avoids zigzag deformity. Lizarov technique can treat infection, non-union deformity, joint contracture, limb shortening simultaneously. There are three geometric variables for deformity correction. Cora, which is inherent deformity, you cannot change the cora. ACA, which is partially under our surgeon control, and osteotomy is completely under surgeon control. ACA depends upon the level, type of deformity, soft tissue hinges, resisting correction, and hardware used. Osteotomy level is based on the anatomy, biology of the bone or soft tissue, and technique and type of fixation. If three variables are coordinated, secondary deformity will not result from deformity correction. Thank you. Thank you for your patient hearing.
Thank you, Rola, for your good cases. But one thing I want to add on is that if you have the children with these various deformities, I think it is mandatory to evaluate them to rule out the metabolic bone disease.
Yeah, sure, sir.
It is very, very
there is
common.
always a if there are deformity in particularly in childbearing children, you have to find out the metabolic bone disease, and you have to treat the metabolic bone disease prior to deformity correction.
Yeah, and one thing is post-infection fascial bar is very common.
Yes, sure, sir.
इसको अंदर सुला दे निर्वाण को लेके जाके कहने का.
बिल्कुल सर, बिल्कुल. And what I want to ask from the panel is how they manage the infection at corticotomy site, because I have encountered 2 to 3 times infection at the corticotomy site, and how they manage it.
I have also encountered the complication you have seen, but just you can reverse it, or you can do a delayed corticotomy. If your medullary canal is infected, then it's better to have a delayed corticotomy.
Yes, you can go for the delayed corticotomy. If there is frank infection, we should go for the delayed corticotomy. No doubt about that, sir.
Yeah.
Rohila sir.
Hani sir.
Evening, sir. If there is a frank infection after you have done the corticotomy and you have proceeded ahead, what we do that stop and still go back and do the bucking at the corticotomy site, wait till the infection subsides, then start transport again, sir.
Yes, you can do that, but there is possibility of poor reason rate.
Exactly, sir.
If the same corticotomy used.
Yes, sir. We have waited a few days, 20 days, and done a compression again and restarted. It has resulted in many cases, sir.
Yes.
Very nice case, sir.
Badhiya.
So the next speaker will be
Dr. Roila, please unshare your screen.
एक मिनट. नहीं, मेरा स्क्रीन तो शेयर हो नहीं रहा मेरे में सर.
नहीं, आपका हो गया, नेक्स्ट स्पीकर होगा ना.
I've done it, sir.
मेरा विजिबल है.
हाँ, विजिबल है.
Yes.
So I will present two cases. My first case is 22-year-old female having tibia vora with shortening with internal rotation deformity. So these are the clinical pictures of the girl having varus with internal rotation deformity with shortening. And these are the pre-operative X-rays. So these are the basic angles we are following from these. This is from the Pele's book. So we are using mechanical LDFA as a 87 as a reference and LDTA as a 89. So these are the preoperative X-ray, and I drew the lines and the angles. So I got the deformity of around 22 degrees, and in the sagittal view, and in the lateral side, it's more or less normal. So then we can correct this deformity by two ways. So the plan one is doing single osteotomy, as Dr. Roila already discussed with you, that we can go for single plan. But when I apply osteotomy at the cora level, so we get a deformed bone, zigzag bone, as he told earlier, that we get a corrected bone but a zigzag bone there. So we correct the angles, and then a Z deformity can occur there. But for a cora, when it meets outside the bone, that kindly
Go ahead.
please other people mute your.
I have muted them, so you can go ahead.
Okay. So when the cora meets outside the bone, so there is multi-apical deformity, as earlier told by the earlier speaker. So in multi-apical deformity, you can draw the cora, and then you can split that cora by a line drawn from first line to the second, that this yellow line should be on the bone, and where it meets, it makes two coras. So according to plan or second plan, I did two osteotomies, and I split that 22 degree of angulation into 12 and 10. So my first osteotomy level is this one, and second I planned for this level. So I did my first osteotomy, and as I know that there is, according to osteotomy rule number 2, because my cora is upside and I am doing osteotomy down, so there has to be some translation. So I accepted that translation and did that osteotomy, and I corrected that rotation along with the translation of the and the deformity with the hexapod. So this is my first osteotomy and correction of the deformity. So I drew the lines again, and then I got that my cora has shifted little bit above, because now this center line is going through the center of the bone. Earlier, it has been drawn to the side of the bone, little bit on the side of the bone. This is going from the side of the bone. This is not exactly in the center, but now it is going into the center of the bone. So my cora has shifted little bit up. So I drew the lines again and again marked the cora. I did my second osteotomy down, and residual correction of the internal rotation was done with the help of hexapod. So this is the final X-rays of the girl, and now the limb is totally aligned, and this is the final function of the patient. So this is my second case. This is 22-year-old male who has osteomyelitis early in the childhood when he was 5 years old. He has procurvatum and varus deformity in the distal third of the tibia with shortening with internal rotation and equinus at the ankle. These are the clinical pictures of the patient. So at the site of deformity, the skin is so much thin and adherent to the bone that it's like a potato peel. It's like a potato peel. So these are the preoperative X-rays of the patient. In the sagittal view, it is around 10 degree of the varus, and in the lateral view, it's the 57 degree of the procurvatum is there. So what I did was osteotomy at the level of the cora. I did that osteotomy along with the segment of the fibula was removed from the lateral side, and percutaneously TA lengthening was done. And then I applied the hexapod along with the Elizarov fixator. This is the osteotomy side at the cura level. And as I told earlier that this is papery thin, so I have got a problem with the wound essence here, which for which I have to give long-term antibiotics and other things, and then ultimately that heal. And then when I start that distraction, I start with the low pace already, but I got a poor regenerate. After the distraction, I have to wait for the 3 weeks to see that there is regenerate, but after 3 weeks, it shows some speculations of the calcification there. So this is then I further continued the correction with the hexapod system. These are the final X-rays after the correction in AP and lateral view. Here the heel ring was removed to mobilize the ankle of the patient. These are the X-rays of the consolidation period. I don't have final X-rays of the fixator removal, but these are the final pictures I do have before the fixator removal, but patient lost to follow up at the final stage. So this is the final pictures I got, and these are the final X-rays. Here the good regenerate is already formed there. So my take-home message is pre-operative planning is key rule for the successful deformity correction. Cora, hinge, and osteotomy sites, these three factors along with the proper application of the osteotomy rules helps the deformity correction in lesser time with minimal deformation of the bones. Minor secondary deformities can occur and it should be acceptable. In case of multi-apical deformity, more than one osteotomy may be required. Thank you so much.
Thank you. Thank you very much for presenting nice cases. One or two comments I want to put on is that if you have the severe scarred skin, then
sir.
you definitely have the regenerate issues.
Yes, sir.
So either you can replace them with the full thickness, so it will not land up in the problems.
Okay, sir.
The most of the time patients are not willing for that, but ideally if you can replace it with a full thickness skin, then you will not land up these regenerate issues. And most of the time, these patients are associated with the foot deformities. So you have to correct the foot deformities also. They are all of them are compensatory, and as time passes, they becomes rigid and painful. So these patients also needs correction of the foot deformity or realignment of the foot also.
Yes, sir.
One comment from I would like to give that in such cases where the skin is adherent to the bone and there is too much deformity, I have done partial correction acute, not full correction with the distraction. I have done the you give incision up to the bone and lift the periosteum along with skin. Then you can have less problem of wound dehiscence and do some acute correction. I think that can, I have done 2-3 cases that can help in less regenerate problem and less wound problem.
Agree, sir. I've done a few cases in the same acute correction, closing wedge, and then the skin problem heals, and you can do lengthening from proximally. Yes.
That can be the other option.
Exactly.
Yes.
Beautifully shown cases, Tarandeep.
Very nice case.
Just can I see one X-ray of your first case, AP view? Tarandeep, can I see your first case?
Sorry, are you saying this?
Yeah, I am requesting you first.
Yes, sir, we are
AP view.
able to see. Go ahead, sir.
Sir, which X-ray, pre-operative or post-operative?
Pre-operative. I just have, I want to, yeah. If we see this X-ray, this is the AP at the knee.
Yes, sir.
Where the patella is centered.
Yes, sir.
Now we forget about the leg and only see the ankle. If we see the ankle, this is not the AP view of the ankle. This is 20-degree
rotation, sir.
rotation.
I already told that it is
Yeah.
internal
No,
rotation.
I am not saying you. I am otherwise telling whenever we see this thing in the X-ray, this means there is 20-degree of rotation because AP of the ankle is showing 20-degree view.
Yes, sir. Definitely.
So, if you start seeing these things in the AP view, full length X-rays, and the ankle is in 20 degree of internal rotation or external rotation, then you will also start having assessment of the rotational issues of the. Similarly, you also can have the femoral.
Yes, sir.
Once you have the full length X-rays, where is the trochanter? From that, you can also assess how much judgment can be made rotational issue of the femur. Suppose in this AP view, we have lateral view of the ankle. That means almost 90 degree of rotation is present.
Yes, sir.
So
Yes,
from
sir.
that angle, beautifully you have explained. Thank you very much, Tanvi.
Thank you,
बिफोर
sir. Thank
इसमें
you.
सर रोटेशन में ना मैं ये कहना चाह रहा था, आई वांट टू से दैट यू गेट द एक्सरे विद सेंटर्ड ऑन नी, विद patella centered on knee. You get the APN lateral X-ray plan that way. Rotation has to be checked clinically by the thigh foot axis. There you decide whether it is internal rotated or external rotated. So rotation cannot be checked on X-rays in a more
It
clear
can
way.
give you some
The
idea,
rotation
but
is clinical perception.
yeah.
I think
the X-ray will give you some idea. If you see the interosseous space,
Yes, sir.
interosseous space between the two bones, it will give you a brief, sort of brief idea. But either you rotation can judge by the either on the prone position by the heel toe angle or
Thigh
heel
foot axis में
leg
prone position,
angle,
sir.
thigh angle. By that you can measure. Clinically, you can measure in a better way.
Better way.
The X-ray will
X-ray
tell you the
either on
interosseous
the
space.
CT scan. You can assess on
Yeah.
CT scan also.
Yeah,
CT scan with the rotational profile.
yeah.
Objective way is CT scan.
Yes.
Otherwise, clinical assessment, and you have to, after clinical assessment, you have to add that thing in support system.
Right, sir. Most difficult, I think, is the rotational issue of the limb.
Yes.
And rotational issue of the limb, clinical, with CT scans, with X-rays, with gait of the patient. I think these are a few things. And especially in the femur, to find out how much is the rotational issue of the femur, you see in the CT scan, AP view, dead AP. Start rotating the femur till you get AP view the hip. That will find out how much is the rotation of that femur. You have full length X-ray, full length CT scans, 3D CT scans. You have deformity which is rotational also in the femur, and you want to really see it. You see first AP view of the hip, start rotating till the AP view of the knee also comes. That much is the rotational issue, something of that. And then also the axial views in which femoral condyle, tibial condyle, and ankle axis as well as femoral, and clinically. I think still I find this is the most difficult. Rotational issue is one of the most difficult issue to understand and then to execute as well.
Dr. Bola, if you have other side with a 10 degree of internal rotation, where will you stop? You will stop at dynamic corrections or you will correct that rotation?
If you're doing acute,
If
you
you
can
are
do it on the OT table only. Okay, till 20 degrees, not more.
okay,
10, 15 degree, 20 degree can be done
fine.
at the OT
Yeah.
table
Not table only,
acutely
yeah.
also. More, you have to take precaution if you are doing internal rotation of the distal foot or distal leg, then it should be less because you will be stretching the LPN. LPN is more
Okay,
important because LPN palsy can occur if you will do too much of internal rotation.
Right.
External rotation I feel you can do more.
The rotational issues of the leg, if only are to be addressed, it's better to deal them at the supramalleolar level. Because if you do at the HTO level, then you have to release the lateral popliteal nerve as well, if they are in larger extent, or you want to do that in acutely correct the correction. That is what
But
I.
you will have the problem of the posterior tibial nerve also. If you are doing the supramedullary, then you have to be careful. If you are creating a larger deformities, then better to correct them gradually rather than correcting them acutely.
Yeah, the nerve issues, they are much more rotational issues, neurovascular issues, if they are dealt in the high tibial osteotomy level, because the lateral popliteal nerve, common peroneal nerve, that will be stretched. But at the supramedullary level, they will be slightly less.
Thank you very much all the speakers for presenting
Okay,
a
sir.
nice
Thank you,
paper.
sir. Thank you very much, sir. Nice
Thank
cases
Thank you
discussion.
very much,
Akanksha,
everybody.
is it okay?
Yes, sir. We can stop the live recording.
Okay.
Thank you, everybody.
Thank you very
Okay,
much.
thank you, everyone.
Thank you, sir.
Thank
Good
you,
Thank
night.
you,
everyone.
sir. Good
Thank
night.
you.
Stopping the recording now.
Oh.
Thank you.
Ending the meeting, sir. Thank you, everybody.
Thank you. Thank you so much, Akanksha.
Thank you, sir. Bye.
Thank you, Akansha.
Thank you so much, sir. Bye-bye.
Thank
Good
you,
night.
Tarandeep. Thank
Thank
you,
you, sir. Thank
Rovila
you.
sir.
Thank you,
Thank you,
Bhola
Meena
sir.
sir, and all the